1 minute. So good evening, everyone. We have around 17 students logged in as of now. Thank you very much again to PCSI and Dr. Sunita Maheshri and Kavita for organizing this educational platform. Nowadays, we are having a parallel DNB program as well. I think every month, which is going on various departments. Last week, we had intensive care program, pediatric cardiac intensive care program. So unfortunately, we don't have students at this point of time. We are going to take students the next season, that is 2022 June batch, which is going to be conducted in the couple of months. So that is the reason we don't have a case. We have a lot of cases, but we don't have a student to present. Neither my consultants are not there. So that's the reason why Kavita asked me to give a talk. I thought a clinical approach to some particular topic is pertinent to this students class rather than any of the management aspects. So I have chosen to talk on the pretricuspid left to right shunts. So if you look at these, you have acyanotic congenital heart diseases, left to right shunt, obstructive diseases, and miscellaneous diseases. Whereas in case of left to right shunts, it is defined as pretricuspid shunt and post-tricuspid shunt. And obstructive diseases, you have right heart obstruction, left heart obstruction, and in miscellaneous, you have regurgitations or other structural abnormalities like absence anomaly. All these things comes under classification. Why we need to do all this classification? In order to diagnose the conditions, to know the natural history, to discuss the prognosis with the family and timing of management. So when to do that? So if you look at the pretricuspid and post-tricuspid shunts, we need to definitely classify into two different categories. The shunt at the level of atrium or above the level of atrium, like in systemic veins, is considered as pretricuspid shunt. Examples: atrial septal defect. It can be primum AST or fossa ovalis defect or sinus venosus AST or common atrium or post-tricuspid shunts. Typical example of pretricuspid above the atrium, typical example is PAPVR or any other communication in the atria like a coronary AV fistula. These are the things which comes under pretricuspid shunt. Whereas a post-tricuspid shunt below the tricuspid wall, it is typically ventricular septal defect, AP window, patent ductus arteriosus. Even though AV canal defect will have both AST and VST, it is classified under the heading of post-tricuspid shunt. Because the pretricuspid shunt's presentation is subtle, most of the times asymptomatic. Post-tricuspid shunts are most of the times symptomatic and they have heart failure. If you don't treat post-tricuspid shunt, they may develop pneumonia, pulmonary arterial hypertension, and other complications like endocarditis and other things. Whereas pretricuspid shunts, their presentation is much later and development of heart failure is rare. Development of pulmonary hypertension is somewhat lesser compared to the post-tricuspid shunt, and prognosis is very good in pretricuspid shunt compared to the post-tricuspid shunt, and the treatment modalities generally are elective in case of pretricuspid, whereas the post-tricuspid, the treatments are much earlier. So these are the precisely important reasons why we should actually differentiate pretricuspid and post-tricuspid shunts. If we take generally the left to right shunts, it can be pretricuspid or post-tricuspid, they can have heart failure. So pretricuspid left to right shunts are atrial septal defect, common atrium and PAPVR we are going to focus predominantly today, whereas we are not going to talk about post-tricuspid shunts, which are typically VST, PDA, AP window. What are the pretricuspid right to left shunt? Anybody would like to write in the chat box? Just to stimulate you, what is pretricuspid right to left shunt? What are the pretricuspid right to left shunts? There are some 25 students are logged in. Anybody can type.
The pulmonary AV malformation.
IVC to LA, PAPVR. Pretricuspid right to left shunt, how PAPVR? It's a partial anomalous pulmonary venous connection. IVC to LA, I agree with that. Pretricuspid right to left shunt is systemic. IVC to LA, I am very happy to see the answer SVC to LA. Any other? Even total anomalous pulmonary venous return is considered as pretricuspid right to left shunt. Okay. Somebody wrote a severe PS with PFO. That is not contributed significantly, whereas an obligatory right to left shunt across the AST, then you have differential diagnosis of a PFO right to left shunt or pulmonary atresia intact septum right to left shunt, okay, or tricuspid atresia with the right to left shunt. Those are all obligatory right to left shunts. Whereas the pretricuspid right to left shunt is typically people call PAPVR, or you can consider that SVC to LA. Somebody wrote pulmonary AVM, so those are the right to left shunts with the normal QP and QS. Normal QP QS means the amount of blood flow across the pulmonary wall is equal to the amount of blood flow across the aortic wall. So that is QP by QS is normal in case of pulmonary AVM, but still you will have right to left shunt across the distal peripheral pulmonary vascular bed. So that is not considered as a pretricuspid shunt. But however, we can proceed with the subsequent slides. So the left to right shunts in general are asymptomatic or having congestive heart failure. Congestive heart failure are predominantly seen in post-tricuspid shunts. In infants, the common symptoms of congestive heart failure are feeding difficulties, presence of a suck rest cycle. Baby takes feeding, stops for a while and takes rest and again restarts feeding. So this is called as typically suck rest cycle. Failure to thrive, recurrent respiratory tract infection, respiratory distress, all these are the symptoms of heart failure due to left to right shunts in infants. Whereas if you look at the cardiovascular system, they will have active precardium, loud P2, shunt murmur, flow murmur. All those things will be present in the presence of a structural heart disease, which is causing heart failure. Somebody wrote, sir, is common atrium left to right or admixture type? I am going to come to that. S1 in AST, loud or soft? We are going to come in that. So heart failure in children in the presence of typically a normal preserved ventricular function or in the presence of left to right shunt, there will be reduced ventricular compliance over the period of time to the myocardial tension. So your sarcomeres will stretch to some extent. If you go on putting the preload to the ventricle, it will go stretch. Beyond a point, it will not stretch. Then they will have heart failure. Sarcomere properties are that. The amount of number of elements of contractile mass is less in children. The ventricular volumes the end-diastolic volume of left ventricle is less, and the heart rate reserve, the heart rate is already high end of their required rate. When you have heart failure, the reserve is less. That's why they decompensate very fast. So reduced ventricular compliance to the degree of stretch of the sarcomere and relatively low contractile mass, less ventricular end-diastolic reserve and heart rate reserve. These are all contributing to the heart failure in children in any left to right shunt. So as I told you, fewer myocyte, greater proportion of connective tissue and the relative RVH. If you take in case of pretricuspid left to right shunt, heart failure is extremely rare. I'm going to tell you next slide and come back. So in pretricuspid shunt, atrial septal defect, if you look at the embryology, you can see a typical atrial septal defect, how it is going to be formed. In the beginning, there will be septum primum, which is going to form the septum and going to fuse with endocardial cushion by crawling down to the inferior posterior aspect onto the endocardial cushion. To have the communication, there will be formation of the fenestrations you can see, and completely fusion of the primum septum to the posterior and endocardial cushion will happen. So there won't be any primum, any communication here, only fenestrations will be there. Suppose if this primum septum doesn't fuse with the endocardial cushion, then you have primum AST. Or if you have the fenestrations which are bigger or multiple, then you will have a fenestrated AST. So what will happen after some time? You have septum secundum which is formed and try to close these fenestrations which are present in the primum septum and leaving a small, an important hole called the foramina ovale, which is important in the fetal circulation. Suppose the foramina ovale is big or secundum septum is not forming completely or not incompletely formed, or primum septum has got more fenestrations, then you will have a secundum or fossa ovalis defect. So various other types like coronary sinus type, SVC type, IVC type, all these are embryological abnormalities which you see, and clinically, hemodynamically, they all present as a single pretricuspid shunt. So you cannot really diagnose whether it is a primum AST or secundum or sinus venosus clinically, but you can only tell there is a pretricuspid shunt, and probably these are the possibilities. So what will happen in case of fetal life? In fetal life, you all know that umbilical vein to the ductus venosus contains the highest amount of oxygen saturation, which will be shunted from inferior vena cava, a transient travel in the right atrium and to the left atrium, and it will be pumped. Whereas in case of a big intraatrial communication, so you have a significant amount of shunt from the left atrium to the right atrium will be there. So how the shunting pattern happens in case of pretricuspid atrial septal defect? So what are the implications? What are the changes during dynamic respiration and all? So during inspiration, there is a fall in intrathoracic pressure. There will be negative pressure. So the SVC, IVC blood, which is coming to the right atrium, will be increased. So the right atrium gets a lot of blood during inspiration. From there, it will go to the right ventricle and then to the lungs. So during inspiration, you see predominantly the systemic venous return. The shunt across the intrathecal communication is somewhat relatively reduced because of the more amount of venous return which is coming down to the right atrium, to the right ventricle. Whereas during expiration, there will be increased pulmonary venous return to the left atrium, and left atrial filling pressures are higher, marginally higher than the right atrium. So you have significant amount of shunt from left atrium to the right atrium during expiration. In Valsalva maneuver, similarly, there will be decreased venous return and increased venous pulling. So your left to right shunt is going to be more. Whereas in cardiac cycle, what will happen? The shunt across the intrathecal communication reaches to its peak in the late systole and early diastole. And rest of the throughout the diastole, there will be diminished shunt in the cardiac cycle of ventricular diastole, because you all know that there is a first rapid filling phase, and after that you have continuous shunt going of blood from the atria to the ventricles. In late diastole, again there is a atrial kick. Atrial kick is there, so you have a shunt from the left atrium to the right atrium. These are the hemodynamics which you regularly see while doing the echocardiogram in case of pretricuspid left right shunt. If you carefully observe while doing the echocardiogram, especially subxified or four-chamber view, the amount of shunt coming to the right atrium, lot of blood will come from the right pulmonary vein, right upper pulmonary vein to the atria will be more, because this is because the proximity of the pulmonary vein close to the interatrial septum. So the right pulmonary vein is very close. That's where the shunt will come from the right pulmonary vein to the somewhat to the right atrium. So that means if you look at the X-ray, maybe I will talk to you that aspect later on rather than at this point of time. If you look at the natural history of the disease, spontaneous closure, do you have anybody has got an idea of the atrial septal defect and its a natural closure? What is the percentage of ASTs they close naturally at 3 years of age? Anybody? Can anybody write in the chat box? There are no answers. Natural history of atrial septal closure is second AST. Primum AST will never be closed. Then sinus venosus AST will never be closed. Either it can be SVC type or IVC type or coronary sinus type. Whereas if the AST is less than 8 millimeter in size, 8 millimeter in size, yes, very good. Close to recent studies have shown, earlier studies somebody wrote to 40% by 3 years, not by 4 years, close to 60% possibility of a closure by natural history. So let us draw conclusions. If a child is having a 6 millimeter AST and whether it will be closed or not closed, you cannot decide in less than 3 years of age. Whereas primum AST and sinus venosus AST, it will never be closed. So you can outrightly tell these are the ASTs will never be closed. Death is extremely rare in isolated AST unless associated complications like pulmonary hypertension, mitral valve disease is present. In an uncomplicated atrial septal defect, close to 13% will have pulmonary artery hypertension in less than 20 years of age group. And they develop Eisenmenger syndrome only in 9% of cases. Whereas this pulmonary hypertension is somewhat slightly higher if the age group more than 40 years. After that, above 60 years, it's unlikely that any new cases which are going to develop a heart failure, usually it happens in the middle age group. And most of the patients are asymptomatic, and usually it will be diagnosed during childhood examination while going for vaccination, other respiratory infection, during pregnancy, during screening for athletes, or during routine healthcare examination. That's how you diagnose AST, and symptomatic individuals are rare, and usually you see in 20% of the cases. The symptoms are predominantly fatigue, palpitations, occasional chest pain, and arrhythmias, whereas in the beyond fourth decade, they may develop a heart failure because of the increased systemic vascular resistance. So the life expectancy is not normal, but the survival curve, if you look at the previous couple of slides, the survival curve is not bad compared to the other congenital heart diseases. It has got a good prognosis. So as long as patients are not having pulmonary hypertension, they are going to have a good prognosis. If you look at the hemodynamics, in an uncomplicated atrial septal defect, you have a left-to-right shunt here to some degree, as long as your left ventricular filling pressures are good. As the age advances, the systemic vascular resistance will be increased. The diastolic properties of the left ventricle will be altered. They will have diastolic dysfunction. Above 40 years, diastolic dysfunction, SVR will be increased. So what will happen? The LA pressure will be increased. LV EDP will be increased. So your net left to right shunt is going to be high. When you see an AST during a childhood, the shunt may be just less than 2:1. If you have a 10 or 15 millimeter atrial septal communication, whereas the same AST above 40 years of age group, you will have significant shunt, a disproportionate shunt to the degree of atrial septal communication. As the shunt increases over the period of time, or in case of infants, some subset of infants where there is a posterior AST, right ventricular thickness is still persisting, where there is a right ventricular failure, then even though your shunt is there to some extent, they will have a significant residual volume, RV dysfunction will be there. These are some of the hemodynamics of AST. You can have same principle in case of fossa valualis defect and sinus venosus defect, whereas in case of primum AST, it is almost always associated with the cleft mitral valve, some degree of mitral regurgitation, and indirect LV to RA shunt, that is left ventricle to the left atrium and then to the right atrium will be there. So they can have variable types of presentation in primum AST. So look at here, somebody asked me common atrium. Who asked? I'm just trying to figure out that. Who asked about common atrium? Yeah, they did not. Somita asked, sir, is common atrium left to right or admixture? Somita, can you please open your microphone? It's a very good question. I like it.
Yes, sir.
So, Somita, what is your understanding of the common atrium? Here you can see beautifully. Okay. You read Perloff. Common atrium will behave like a large atrial septal defect. So this is a case of common atrium. You can see the color, that is the pulmonary veins which are definitely coming to the right side of the atrium. Can you see that?
Yes, sir.
So if you do cardiac catheterization or if you check the pressures, the left side of the atria will have 1 to millimeter more pressure compared to the right side of the atrium. That is the reason in the beginning, common atrium will present like interatrial communication, large fossa ovalis defect, and it's an extremely rare situation that they will have complete admixture in the atrium. So the atrial admixture is essentially determined by at least 3 factors. Would you like to answer or can I tell?
So the end diastolic pressure of right ventricle.
I like your answer. It is a relative resistance of the ventricles. A relative resistance of the ventricle. Even though if you have right ventricle, end diastolic pressure is higher, you can have a right to left shunt or admixture in the common atrium. So relative resistance of the ventricles, presence of AV valve regurgitation. You can see in this particular case, there is a mitral regurgitation due to cleft mitral valve. You can see the mitral regurgitation. So the mitral regurgitation may go into the left atrium. Tricuspid regurgitation can, mitral regurgitation can go into left atrium. Tricuspid regurgitation can go into right atrium. So there will be sometimes a crisscrossing of the AV valve regurgitations will be present. And finally, anomalous systemic venous return. If you have bilateral superior vena cava, the left superior vena cava will not be having roofing, that will not drain to the corner sinus, that will drain directly to the left side of the atrium. So multiple factors like relative resistance of the ventricles, development of pulmonary hypertension, presence of AV valve regurgitations, and unusual drainage of the systemic veins will be the responsible for cyanosis or admixture in the common atrium. So the approach is generally evaluation of the history, general appearance, ventricular dominance, great vessel relationship, second order sound, murmurs, chest X-ray, ECG are going to be useful. And finally, echo will tell you the diagnosis. These are all integral part of your clinical evaluation. In pretricuspid shunt, infants and young children are generally asymptomatic, and it's very difficult to appreciate this bleed because you don't have a significant left direction at that particular age. The clinical findings may not be obvious like in young children, like in grown-up children. So it's not that common to identify ASD. The physician who examined the child during infancy may miss. He may again find out when child becomes little bit older, or presence of associated conditions like a mild valvular PS, a mild tricuspid regurgitation. It's obvious that you can identify these kind of conditions. Otherwise, by and large, they are asymptomatic, and clinical examination may not readily give clues to diagnose the condition. As I told you earlier, the shortness of breath is present, dyspnea is present only in the above 4th decade, unless child is having a heart failure, that I am going to tell you. Presence of exercise-induced fatigue, exercise intolerance, palpitations due to right ventricular volume overload situation, so it will give palpitations. And it's not unusual, it's not really, it's rare to have recurrent respiratory tract infection in atrial septal defect, unlike you have commonly seen in case of pretricuspid shunt. Often, the patient may have this kind of symptoms during pregnancy. Again, it's a hyperdynamic circulation, volume overload situation. In the presence of left direction, the findings will be exaggerated. You will be able to diagnose. So what is your understanding of heart failure in atrial septal defect? Anybody? Do you see heart failure in AST? Number one, heart failure in AST, you may see in advanced age where SVR increases and there is a diastolic dysfunction of the left ventricle leading to the disproportionate left to right shunt across the intraatrial communication. Associated valvular disease, associated myocardial disease, and undiagnosed post-tricuspid shunt. These are all responsible for heart failure in the presence of atrial septal defect. So you all should know this and understand this is a common question which is asked in the examination. So now I am going to ask you, I'll go back to the previous slide, which where, yeah. So anybody would like to tell the reasons, generally speaking, heart failure is a rare event in atrial septal defect in children. What are the clinical subsets and mechanisms where you see heart failure in children in the presence of AST? AST and heart failure in children. Can anybody point out? I just described some, but more I want. So I will answer. Number one is presence of posterior AST. A posterior AST is intraatrial communication in the posterior part of the septum. So what will happen if you don't have posterior part of the intraatrial septum? The pulmonary veins, right pulmonary veins, will shunt predominantly to the left atrium. Predominantly will shunt from left atrium to the right atrium. So number one, posterior AST, I suggest all of you should read a book called Kirklin. Kirklin, you read today, atrial septal defect, and find out the reasons and mechanisms for heart failure. He will nicely mention that posterior atrial septal defect. Number two, in non-compliant right ventricle. Right ventricle has got its own stiffness. Normally, the left ventricle like coconut, right ventricle is like a balloon. So if you put water in balloon, it will distend. It will distend for long time. Whereas coconut, it cannot accommodate, it will eject. So similarly, if right ventricle behaves like a left ventricle, that means it's a non-compliant. The right ventricular hypertrophy, which is present in fetal life, which did not regress. So you don't have compliant like a balloon nature, then they develop a heart failure. So 10% of the atrial, 5% of the atrial septal defect associated with the heart failure due to non-compliant right ventricle. And the second cause is posterior AST. And the third cause, somebody mentioned very nicely, a mitral valve disease. I want to consider as the Lutenbecker syndrome alone, presence of mitral valve disease itself can cause a heart failure. And of course, we mentioned that the post-tricuspid, associated post-tricuspid shunt and pulmonary vascular disease and other systemic disorders and anemia. So in case of atrial septal defect, you have to go systematically. Number one, look at the precordial bulging. One of the commonest cause for the precordial bulging is the AST. You know why? Because the right ventricle can dilate much more compared to the left ventricle. And the right ventricle is present just below the sternum, anterior ventricle, compared to the left ventricle. So that's the reason precordial bulging is quite commonly seen in atrial septal defect compared to the other structural problems. Precordial pulsations, parasternal heave, subxiphoid pulsations. Are there any palpable sounds, thrills? Are very, very important. Then subsequently heart sounds and murmurs. So now look at this. This is the normal right ventricle, left ventricle. When right ventricle is dilated quite significantly, you have parasternal pulsations in the presence of normal right ventricular pressure and normal pulmonary artery pressure. Your right ventricular outflow tracts are dilated. So you will have parasternal pulsations. If they develop pulmonary hypertension, then you will have parasternal heave. So if you carefully look at, you will not have a localized apex. You will have diffuse apex. The apical impulse is defined as lowermost and outermost localized less than half centimeter pulsations in the left side of the chest produced by the heart is called as apical impulse. Whereas when the right ventricle is dilated, the heart is rotated. You can see that heart is rotated towards posteriorly. So the left ventricle, which is forming the apex, which is no more forming, which is occupied by the right ventricle. Right ventricle is a triangle shaped structure and dilated, which cannot form the localized apex. So that's why you will have diffuse apical impulse in the midclavicular or medial to the midclavicular line. And the same pulsations you will see in the left parasternal region, that is due to right ventricular outflow tract, which is dilated. So if you read carefully Perloff Clinical Examination, a small book which is available, Perloff, there are 3 books written by Professor Perloff. One is Clinical Recognition of Congenital Heart Disease, Adult Congenital Heart Disease, and Clinical Examination, a small book. And in that clearly mentions that you will have a lateral retraction and medial elevation will be there, that is during the cardiac contraction, that you can identify easily in case of pretricuspid shunts. So when you examine, you have first heart sound and second heart sound, third and fourth heart sound, whether it is present or not, you have to mention that. Somebody asked first heart sound whether it is normal or soft or loud. So in case of atrial septal defect, it's by and large, it's a normal first heart sound. If there is a mitral regurgitation, then they become soft. In the presence of pulmonary, exaggerated pulmonary component, then again relatively it appears it is soft. Then there is a tachycardia, it again becomes louder. So by and large, the first heart sound will be normal unless you have an Epstein's anomaly where you will appreciate split first heart sound. So that's why in Epstein's anomaly, when you are examining, you will have multiple sounds. The clinical hallmark, if you want to diagnose atrial septal defect, you should have fixed wide split. Absolutely, there is no argument in that. Fixed wide split and pulmonary ejection murmur. These are the 2 important clinical points which you should have. Then third important thing is a tricuspid diastolic murmur. So a fixed wide split, there are many mechanisms are written, but importantly, we'll just discuss briefly about the hemodynamics. As soon as you breathe, negative intrathoracic pressure, the venous return to the heart will be increased. The right ventricular end-diastolic volume will be increased. During cardiac contraction, the right ventricular stroke volume will be increased. Right ventricular ejection time will be increased. And the pulmonary closure time will be very much delayed. So the hangout interval, it's called as hangout interval, will be delayed. This is because the ejection of right ventricular blood, which goes to the distal low resistance pulmonary arteries. There is recoiling properties of the pulmonary arteries, which is causing a drop in the resistance there, and you will have delayed closure time of the pulmonary valve compared to the aortic valve. Then you will have a wide split. The fixed is because during inspiration, the more volume will come from the systemic venous return and also some amount of left right shunt. And during expiration, the left right shunt will maintain the right ventricular end-diastolic volume, which is more. And as all of you know that the right ventricle has got properties of a complaint properties, which is dilated. So your right ventricular volumes will be high. So that's where you have delayed closure leading to the fixed wide splitting will be there. So the important aspect is pulmonary ejection murmur. So the right ventricular outflow tract is dilated. When you see the pericardium, there will be pulsations. And when you palpate, the pulsations may be palpable, but you will not have parasternal heave. Parasternal heave you get only when they develop pulmonary arterial hypertension. Otherwise, no parasternal heave. It's only visible pulsations will be there. You may appreciate grade 1 parasternal heave, but grade 2, grade 3 usually suggested there is a development of pulmonary hypertension. So the amount of blood which is going through the right ventricular outflow tract across the pulmonary valve will give a flow murmur called pulmonary ejection murmur. This pulmonary ejection murmur is a short mid-systolic murmur and which is never beyond grade 3/6. You should remember that whenever the murmur is more than grade 3/6 and murmur is long, then it is not atrial septal defect, it is associated pulmonary valvular stenosis. So the P2 loudness is very important when you are talking about the pretricuspid shunt, whether pulmonary component is equally loud at the when compared to the aortic valve, or it is louder than the aortic valve, which is very important here. If it is equally heard, which is normal, and it is louder, then it should be associated with the parasternal heave, and subsequent heave usually suggests of pulmonary hypertension. So what is the diagnosis here? Anybody? What is the disease? What is the structural heart problem which is associated? Anybody would like to tell? So what is the abnormality? Holt-Oram syndrome. It is not TAR. TAR is thrombocytopenia and absent radius. It is absent radius and finger, you can see that, and spine deformity associated with atrial septal communication. Usually it is nothing but it is an autosomal dominated disorder. So now going to the differential diagnosis of it, and I did not tell you about what is that called as tricuspid diastolic murmur. So the amount of blood which is going through the tricuspid valve will produce a tricuspid diastolic murmur. This is, if you auscultate carefully in a thin individual, you appreciate most of the times. Most of the left to right shunt, pretricuspid shunt, this is quite common. Unless patient is having pulmonary hypertension or obesity patient, it's somewhat difficult, or presence of pulmonary stenosis, it's difficult, otherwise it's quite common. In case of partial anomalous pulmonary venous return, you may not appreciate a fixed split. It may be variable, but definitely it will be wide. I am finding very difficult to define it is wide. In a normal child, during inspiration, you will appreciate the split very well, and during expiration, you don't appreciate. In case of PVA, PVR, it's distantly heard, but definitely during expiration, the split, it will come down. So probably that is called as a variable split. Whereas in case of atrial septal defect, the splitting is completely, it is wide and fixed throughout the cardiac cycle. So other differential diagnoses are tricuspid wall disease, right ventricular disease, valvular PS, and anomalous pulmonary venous drainage. So in case of atrial septal defect, the shunt is from the left atrium to the right atrium. In case of PAPVR, the shunt is either at the vena cava level, like a vertical vein, two pulmonary veins or one pulmonary vein draining vertically and then draining to innominate vein, or two pulmonary veins may be draining to the superior vena cava, or a pulmonary vein is draining directly to the right atrium is possible. Sometimes a shunt from left ventricle to the right atrium is technically called as a pretricuspid shunt, but they behave like a post-tricuspid shunt in terms of murmur. A murmur will be a louder pansystolic murmur will be there because it's from left ventricle to the right atrium, even though it is hemodynamically behave like a left right shunt. So these are some of the conditions where technically you can call it as a pretricuspid shunt like AST, PAPVR, LV to RA shunt, RSV to RA, and coronary AV fistula. But based on their murmur, based on their presentation, you classify them you put a differential diagnosis at various level. Like LV to RA shunt, you put them in differential diagnosis of ventricular septal defect, even though hemodynamically it behaves that. Whereas coronary AV fistula, you consider them under the continuous murmur, and RSOB to RA, again acute presentation, they will have heart failure, and again you can consider them at various level. So I will answer your chart box. Let me go a little bit forward. Now tricuspid wall disease. What are the important tricuspid wall disease differential diagnosis is Epstein's anomaly. In Epstein's anomaly, you all know that the atrialization of the ventricle, there will be tricuspid wall, which is much lower compared to the mitral wall, especially the septal tricuspid leaflet and posterior tricuspid leaflet, whereas anterior tricuspid leaflet will be in normal location, but it is side-like abnormal valve will be there. So these people will have normotensive TR, tricuspid regurgitation, leading to early systolic murmur. There will be multiple sounds, a split first heart sound, split second heart sound, and non-ejection click due to an abnormal anterior tricuspid valve. So if you look at the auscultation, you will have parasternal pulsation, but it's an extremely rare phenomenon to have the parasternal heave. I have not seen Epstein's anomaly will have parasternal heave because it's a normotensive TR. You will have parasternal pulsations, you will have diffuse right ventricular apex, and you can have split first heart sound, and there will be split second heart sound, non-ejection click, and S3, right ventricular MDM or S3 may be there. So this is how the Epstein's anomaly will be presented. Whereas right ventricular cardiomyopathy or right ventricular endocardial fibroelastosis, endomyocardial fibrosis from Kerala people, I have seen so many cases when I was studying at the Sri Chaitanya Institute of Medical Sciences, presenting with right heart failure and diagnosing RV, endocardial myofibrosis. They will have heart failure, raised JVP, again parasternal pulsations and diffuse RV pulse, and you can have S3 and S4. You will have S3 and S4, first heart sound will be soft, you won't appreciate a fixed wide splitting, and there won't be any kind of pulmonary ejection murmur. You will have parasternal pulsations, no parasternal heave, presence of S3 and S4 in the presence of heart failure is clinically, you will tell that this is RV cardiomyopathy. RV cardiomyopathy will have soft first heart sound, a normal second heart sound, S3 and S4, right ventricular parasternal pulsations and right ventricular apex, no ejection systolic murmur. There may be flow murmur, but not significant, and there won't be any MDM, no wide fixed splitting. So here you can see a 2-year-old child presenting with, referred to us with abnormal auscultation. When we see that there is a fixed wide split, short ejection systolic murmur. If you look at the ECG, a 12-lead ECG of standardization, standard leads to full standard of standardization, chest leads, full standardization of standard leads, showing that normal PR interval, normal P wave, QRS axis is right axis around plus 90, and there is a right bundle branch block. It is consistent with atrial septal defect, fossa ovalis, because right axis, and you are going to diagnose this as atrial septal defect. So, but actually, this is, I don't have that picture for some reason, I think it's deleted. It is not atrial septal defect. Let me see whether I have that picture. No, it is actually case of partial anomalous pulmonary venous return. So what will happen in PAPVR or in case of atrial septal defect, there will be dilation of the right ventricle, right ventricular body and right ventricular outflow tract, which is going to be significantly dilated in pretricuspid shunt, leading to delayed conduction in the outflow tract, leading to RSR or N-shape or right bundle branch block. Actually, that child was having a PAPVR, not the not the atrial septal defect. Now, if you look at this particular ECG, a 12-lead ECG, I always keep this ECG. I took it from Professor Savitri Srivatsava ma'am, one of our senior most pediatric cardiologists in the country, is the mother of pediatric cardiology in our country. You can see that sinus rhythm, P wave normal, PR interval is normal, QRS axis is left axis deviation, and there is a right bundle RSR here, and LV forces are quite significantly seen, suggestive of there's a left axis with the first prolonged PR interval, and right bundle branch block is suggestive of a primum AST, and presence of significant left ventricular forces, which suggests that patient may be having left ventricular dominance due to mitral regurgitation, that is again is due to cleft mitral valve. So the mitral regurgitation in atrial septal defect, a fossa ovalis defect, it is due to MVP or rheumatic heart disease or cleft mitral valve in case of a primum AST. So any patient who is having a left ventricular apex in the presence of clinically wide fixed split and ejection murmur, usually it suggests that associated mitral valve disease. If the heart failure is significant, cardiomegaly, and there is a loud murmur, long murmur, 4/6 ejection systolic murmur, and usually it suggests it's a Luton-Becker syndrome. In Luton-Becker syndrome, you will have cardiomegaly, heart failure, a disproportionate murmur to the degree of the shunt, usually it will be there. So mitral regurgitation and AST can have pulsatile liver, because mitral regurgitation is quite significant, which is shunting left to right shunt, and cardiac enlargement is out of proportion to the left to right shunt, and murmur of MR will be there, or even mitral Luton-Becker syndrome will have more or less similar physical findings. A pulsatile liver in case of AST usually suggests it may be due to pulmonary hypertension, or it may be due to associated mitral myocardial disease. In case of Luton-Becker syndrome, because of the mitral stenosis, the amount of shunt through the AST, which is quite significant, you will have wide fixed splitting, ejection systolic murmur beyond grade 3 will be there, and mitral stenosis murmur may not be there because the amount of blood which is going through the mitral valve may be lesser to produce that kind of a pre-systolic accentuation of the mid-diastolic murmur. Associated pulmonary stenosis you will have left parasternal heave, systolic thrill over the pulmonary area, and there will be inconstant ejection click, which is very important in the presence of a fixed wide split and inconstant ejection click. You are going to diagnose that there is a pulmonary stenosis. If the murmur, a flow murmur, which is out of proportionate, that is associated with the thrill, you should always consider a differential diagnosis of associated valvular PS in the presence of atrial septal defect. Peripheral PS, the murmurs will be loud and present all over the chest. Even if you look at the atrial septal defect, the murmur is audible on the right parasternal area, because the amount of flow which is going to right pulmonary artery is quite significant in case of atrial septal defect. Probably that could be the reason why right upper pulmonary vein is directly communicated to the right atrium. So you are having a pressure difference is significantly high from right atrium to the left atrium, then your shunt will become more. For an example, in case of PAPVR, if one pulmonary vein is draining to the innominate vein, you have around 33% shunt. Normal pulmonary vein contribute around 25% of each pulmonary vein. In the presence of PAPVR, it is not 25%, it is 33%, because your gradient from LA to RA, pulmonary vein to LA versus pulmonary vein to systemic vein is high. Pulmonary vein to systemic gradient is high, that's why the amount of shunt is high in case of PAPVR compared to the pulmonary vein which is draining to the left atrium. So when you have associated peripheral PS, you have widely radiated murmur over the lung fields will be there. If they develop pulmonary artery hypertension, parasternal heave, loud pulmonary component, the pulmonary ejection systolic murmur will become shortened, the disappearance of tricuspid diastolic murmur will be there, and neo development of pulmonary regurgitation and tricuspid regurgitation will be there if they develop pulmonary artery hypertension. You can see the X-ray here, a child with the X-ray of with atrial septal defect, you have cardiomegaly, right atrial enlargement, and there is the right pulmonary artery is dilated and plethora. In an adult, quite a significant shunt which is showing plethora, and also right pulmonary artery is dilated. So echocardiogram will give you definitely a lot of information about the location, size, associated abnormalities, presence of pulmonary hypertension, and regurgitations. So right atrial, right ventricular enlargement, which you can see in M-word as a paradoxical motion of the septal motion. Pulmonary regurgitation can be assessed by the TR, PR, and other things. Pulmonary veins, PS, mitral valve disease to be assessed. This is what the paradoxical septal motion you will see in this case. That the sinus venous atrial septal defect. This is the primum atrial septal defect. And you all know that the common practice which worldwide do, atrial septal defect can be closed above 3 years of age group in the world. Now it has come down to the 2 years of age group. Any child who has got large AST can be closed above 2 years of age surgically, whereas interventionally above 3 years, above 10 kilograms. A primum AST can be closed above 1 year of age if they have associated mitral regurgitation. A common atrium based on the symptoms, if child is having symptoms in the infancy, should be closed. If they are asymptomatic, can be closed above 1 year of age. You don't keep common atrium for long time because the pulmonary hypertension is much earlier in common atrium compared to the fossa vivalis defects or AV canal defects. And device closure, you all know. I'm not going to show anything. I will show you one case example. This is a 44-year-old man presented with the antiseptal MI in 2011, shortness of breath and progressive dyspnea and worsen. He was having a wide fixed split. You can see large AST here, This is the right ventricle. I'm just going to show you the left ventricle also. Right ventricle is dilated here. That the atrial septal communication. My computer unnecessarily, I pressed this. Computer stopped working on this. So this patient is having left ventricular volume which is increased. Left ventricular dysfunction. There's a left ventricular aneurysm. The shunt is quite significant, as you see that the right heart is dilated in this particular patient. Yeah, now it started working. Again, I unnecessarily took it. So I will go to the next slide then. So assessment.
Recording stopped.
Assessment.
Recording in progress.
So meanwhile, we will see the chart box. So dysplastic tricuspid valve. Indications of AST closure in elderly. Okay. Good questions are there. I'll just stop sharing and then reshare it so that we can, yeah, still doesn't work. I'll just stop sharing, then close the PPT. Do the end task.
Recording stopped.
I think we unnecessarily messed up at the end. Okay, I'll go to the next slide. So this particular patient is having a significant shunt. I don't know why it is going to the same slide. So we close it with the fenestration closure done.
Doc, you got the chat box?
Yeah, I think we'll stop presentation. We'll go to the question and answers.
Recording in progress.
Stop sharing. So yeah, let us see question and answers. Sir, can you explain how to
Recording stopped.
type of sinus venosus AST? So you go to the subsified view. And
Recording in progress.
sagittal view, subsified sagittal view. So the inferior vena cava will be seen draining into the inferior vena cava, left atrium, right atrium will be seen. The septum, which is present, IVC or a junction, IVC-LA junction will be absent. It is commonly associated with partial anomalous pulmonary venous return. Right lower pulmonary vein is associated with this. So that's how you identify sinus venosus AST of IVC type. Subsified sagittal view will give a lot of information. Many times we get child less than 1 year for AST repair. Kindly elaborate on extent salient point for early surgical repair. Very good pertinent question from the pediatric cardiologist point of view. So AST, as I told you, generally they are asymptomatic, no heart failure. If you want to close AST during infancy, should have heart failure. The heart failure reasons are a non-compliant right ventricle, where right ventricle is thick. That means the right ventricle did not lose his thickness, so it is not stretchable. Heart failure will be there. Posterior AST, the AST is located posteriorly, very large. So pulmonary venous, as if it is like a TAPV D. D means drainage. It appears like that. The magnitude of shunt is high. And associated post-tricuspid shunts, like any PDA, muscular VSTs, then presence of mitral valve disease. These are some of the indications. There is another indication, a preterm PDA, preterm baby has AST, they get treatment surfactant, oxygen for long time, they develop bronchopulmonary dysplasia. They develop early pulmonary hypertension and heart failure, and they will have failure to thrive. These are some of the subsets which you can close much earlier. Somebody wrote, if RV compliance does not decrease, won't the right to left shunt not be significant? No, it is actually RV has got a property to dilate to some extent, but RV pressures, inside RV pressures is not high, no pulmonary hypertension. You have left to right shunt, but you have heart failure. It is not that as soon as RV thickness is there, you will have right to left shunt. It is not like that. It's a compliance properties which are lost. That's why RV and LV both play a major role in this situation. Not only LV, RV also has got somewhat important properties. Indications for closure in elderly. I want you to read one article, a multi-center trial, which was published in 1995 NEJ. They actually studied, it's a European trial predominantly published from Germany, European trial where AST should be closed in elderly or not. The important message from the study showed that AST should be closed. If you don't close, their functional class deterioration will be there, and they develop a pulmonary hypertension, they develop a heart failure. That's why AST should be closed in elderly. You are not going to prevent arrhythmias. Whether you close or don't close, arrhythmias are going to come in the presence of AST or after closing. Then dysplastic tricuspid valve. I don't understand dysplastic tricuspid valve, but a congenital tricuspid anomaly where septal tricuspid leaflet is tethered, a short chordae will be there. They will have normotensive TR. Usually they will have early systolic murmur. Because preload is increased, they will have a probably wide variable splitting in this condition. There will be right ventricular dilation. Somebody wrote how to differentiate between PFO and AST and echo, any criteria. So by and large, if you have two flaps, flap is a PFO by definition always should shunt right to left shunt. But in the presence of post-tricuspid shunt or any of the collateral anemia, if left heart pressures, myocardial disease, mitral disease, the PFO can shunt left to right shunt. You should have a two septum, that is a primum and secundum. Then only it is called as a PFO. Otherwise, if you don't have a clear cut a T sign lower and outer, it is called as an atrial septal defect. Is AST Eisenmenger, how will you explain wide and fixed split? In atrial septal defect, there will be right ventricular volume, always it is increased. As I shown you the hemodynamic slide, the right ventricular end-diastolic volume is high because right heart is very much dilated. So the ejection time will be increased even if the shunt has come down. It will never become complete right to left shunt in AST. Remember that there will be always left to right shunt and there will be some right to left shunt in the cardiac cycle. So you will have fixed wide split. That's the reason you will never get a regressed cardiac enlargement which is present, which will never be regressed in case of atrial septal defect. So I think a time has come that we have to wind up.